Any apologies, Stephen?
Apologies from Fiona Duncan and Fiona Malcolm.
Thank you, Stephen. And just to remind everyone, just as I saw bring up on the screen there, that the meeting has been recorded and will be available on the board's website. Probably just a couple of items of housekeeping before we really kick off with the meeting today. Probably just I'm very pleased to note that we received the vast majority of the papers in good time for this meeting, which has given us all time to read and digest. So I would probably emphasise to those presenting the reports that yes, we have read, we have digested. So if opening remarks could be limited to the key points of those reports so that we can then maximise time for discussion and comments by committee members. I think that would be really good, and I'll make sure I pick that up with other members, other presenters as they come in. And probably just a slight change to the agenda, which I'm apologies, I'm going to drop on everyone today. You'll see it at item 3.5. We've got the the responses to the internal audit reports on delayed discharges and complex care packages. What I'm going to suggest we do is we pick up the main themes of those reports as we talk about other items on the agenda. We can come back to those reports. So rather than talking about them in the abstract, when we're at the IPQR, for instance, I think we can take the findings of the internal audit report on delayed discharges and see how that's factoring in, impacting on our performance, or actually, hopefully more, that the improvement plan associated with that internal audit report is actually helping us to manage delayed discharges. And I think we're certainly going to talk about learning disability and complex care packages when we talk about finance, although I'm a bit uncomfortable at using that heading to talk about a process for agreeing complex passages. I think is a good way of bringing that in. And we can still talk about the internal audit reports, but I think it gives us a little bit of context just to actually put the findings and the recommendations and what we're actually doing into a real live situation. And obviously Pam's chief officer report, which I think we'll also bring in under IPQR, has got a significant amount about the 90-day target, and I think that all ties together quite nicely. So we'll move on to item 1.2. Any declarations of interest that anyone would like to make in relation to any items on the agenda? Not seeing any hands, so we will not record any declarations of interest. We'll move on to the draft note minute of our meeting on the 10th of July, and I will first of all take that. Oh, Christopher.
It's an incredibly minor point, and I wasn't present, but I did send in my apologies.
No, we will capture that.
I don't really think noting my apologies is very significant either way, but I just pointed out.
No, you were kind enough to put in your apologies. We should capture that in the minute of the meeting, Christopher. Thank you very much. So we'll amend the minutes to reflect Councillor Bitt's apologies, Stephen. And if there's no more suggested amendments, we will record those with that small amendment as a true record of our meeting on the 10th of July. We've then got attached the rolling actions as a spreadsheet with your papers, with the 2 rolling actions, which I just want to pause on briefly, which came out of discussion at our last committee meeting. We've got number 1, which is on an update to be provided on learning disability spend in 23-24 and how this will roll forward into 24-25. And I think, Elaine, we can pick that up under the finance section, because I think there's still quite a significant pressure being forecast there. And I think as well we can bring in the findings of the internal audit report to see how we want to take that forward. Elaine.
Jerry, if it's okay, can I bring that back to the next meeting? We're doing a piece of work at the moment just around how that's all governed and the process for the approvals, and I'm wanting to tie it back into that, so I'll have a bit more detail for the next meeting.
Yeah, but we are going to pick it up today as well.
Yeah, okay.
Just so we're sure about that, we're not deferring discussion until the next meeting. It was raised at the last meeting, so we are going to pick it up today in the context of a significant financial challenge and a very challenging internal audit report. And then we also had on learning disability, we had raised a question. I think Joanne had raised a question on the number of health checks that are actually going to be undertaken for those people with a learning disability. I think there was recognition in the paper that we were not going to be able to do 100%, and it was to get some idea of where we might be. I don't know if Arlene is with us today, Pam, or you're able to provide an update on that.
Arlene is here, Chair.
There, yeah. Sorry, Arlene, I couldn't see you on my screen. Thank you, so apologies.
Not at all, hiding in a corner. Unfortunately, I wasn't able to get that information for you. The team are still working through the plan and the projection of the plan to the end of the year. They have started to do some of the work now, but they hadn't projected it, so I'll have that for next committee.
Okay, thank you very much, Arlene. We'll record that.
That's easier.
Okay, yeah, I think as soon as you get it, give it to Stephen, and he can circulate it, and then we can just move on from there. Thank you very much indeed. So we'll record. We put the update into the spreadsheet, Stephen, to record that. Okay, we've now got any other matters arising on those minutes which anyone would like to raise, which we're not going to cover later on in the agenda. Nope, no hands. Thank you very much indeed. So we'll move on to item 2 in the agenda, the year-to-date financial position. My agenda says month 3, but I think the paper actually says month 3. My agenda says month 4, but I think the actual paper says month 3. I think it's month 3, and Elaine might be able to give us a verbal update on where we're looking at month 4. So I'll hand over to Elaine. Thank you.
I've just shared the screen, so I know these have all been circulated, and given what Jerry said about trying to move through quickly, I won't go into all the detail, but happy to take questions at the end. So we've got the graph here that's shown a number of different scenarios. Where we currently are is that dotted line in blue. So members might be aware that the board has agreed to an amendment to the financial plan that was submitted to Scottish Government. So while Scottish Government are still holding us to delivering to a break-even of 28.4 million, and that's still the target that they are expecting us to work towards, it was agreed with the board that we would work towards a target of 50.6 million of a deficit, which takes into account delivery of all the value and efficiency savings, cost reductions and cost improvements that we're likely to make. So that's pushing some of that choices element that was included within the finance plan in March into future years as we develop programmes and work around that. So our forecast year-end deficit is 49.7 million, and at this point in time we are still assuming that additional activity will allow us to deliver a break-even position within adult social care. So that position's 21.3 million adrift from the brokerage limit, but it is slightly better than the revised target that was agreed with board at the end of May. Just jump to the partnership position. So we've got a overspend year to date reported of 6.9 million, and that's forecast to increase to 7.3 million. And again, we're reflecting here the assumption that additional activity will allow a break-even position to be delivered within adult social care. We've got a number of pressures within the service. We are still seeing prescribing coming through ahead of where we expected it to be. And again, the volume and the cost of drugs is continuing to increase on a month-by-month basis. And the information that we're getting is that month 3 of this financial year actually saw the highest number of scripts processed for, the highest number of scripts processed since they started recording it in this way. We're assuming that the value and efficiency target of 5.71 within adult social care will be delivered as well. And we'll see that we're still having significant spend on supplementary staffing costs, with approximately 5.4 million being spent on those year to date at the end of month 3. We've also built in 1.5 million in respect of out-of-area placements, and we're continuing the work to see if it's possible to repatriate, and also in discussions around the level of charges that we're seeing coming from that provider. So the adult social care position here, we've got the breakdown across the different service areas. And at the moment, we are forecasting an outturn, just to pick up on that specific learning disability point, we're forecasting an outturn in learning disability of 56 million. So that's actually tracking about 11 million ahead of where we were in 2023, 2024. So you'll see that's reflected in the forecast overspend there. So we are setting the budget based on historical activity because we take that at a point in time. So we do need to look at the number of packages that have been approved, and we're doing an exercise around that at the moment, but also looking around the governance for approval of packages as well. Within our in-house care homes, we are still seeing significant usage of agency nursing staff, so just under £880,000 at the end of month 3, and the two biggest users continue to be Home Farm and Mains House, which are two of the homes that NHS Highland had assumed running off from the independent sector. We're still making additional payments to providers, so there's about 1.5 million built into the plan there. There's a note there that the 24-25 quantum is still to be agreed. That has now been done. We're just waiting on the formal approval letter. So the funding position improved by about £6 million, but unfortunately we are seeing an acceleration of costs, as you can see from learning disability. So that will be reflected in the month 4 position with a bit more detail to be presented once we've done the month 4 reporting. Looking at North Highland communities, the overspend there of just under 2 million year to date and forecast, excuse me, excuse me. So, sorry. Apologies. So our forecast that we're reporting at the moment within health, we are seeing vacancies mitigating against some cost pressures within enhanced community services and chronic pain. These are two services where we've got elements of the service which are unfunded, but they are beginning to come back down to closer to the actual funding envelope in the budget position that we've got. Within adult social care, our main pressures at the moment are independent sector provision within particularly Inverness and Nairn and Rossshire, Badenoch and Strathspey. Let's jump on. So within mental health, we've got an overspend year to date, just over £1 million, and we're forecasting that will increase to 4.3 by the end of the financial year. Health's the main driver for the overspend position within mental health, and it continues to be the use of agency nursing and medical locums. But we have got a significant piece of work ongoing at the moment to reduce those costs, and we're seeing some really positive results, especially around the agency nurse reduction within mental health. We've seen two specific drugs coming through that are causing a pressure there. So we've seen Buvidal and Clozapine, and that's included within the overall board position. And as I mentioned, the out-of-area costs. Within primary care, the overspend that we're reporting or forecasting towards the end of the year is just over 2.8 million. Here we see the big pressure within prescribing, so that's a 2.7 million pounds overspend that's been built into the year end. We're still seeing a significant use of locums, especially within our 2C practices, but that is also coming down as we've had some successful recruitment campaigns within the Allness and Invergordon practice, so we're beginning to see those coming down as the months pass. The overall position has been mitigated by a number of vacancies within primary care and the general dental service, but obviously that's having a knock-on impact within the service provision within the dental service. At the moment, the SG allocations for primary care are yet to be confirmed. We have had an awful lot of allocations confirmed at the end of Q1, but that's one that's still outstanding, but we're not expecting any issue with that. Cost reduction, cost improvement programme, the details all there. I think we've went through that before, so I'll just jump on. We've got the value and efficiency dashboard. So we are continuing to meet every fortnight to review the programmes of work within the value and efficiency programme. We're getting into a schedule where every fortnight the SROs are coming and presenting on a specific piece of work. Where we are seeing improvements is around the mental health agency nursing reduction and also within the locums within 2C practices. The biggest element of this programme is around supplementary staffing and trying to mitigate some of the increases in drugs costs. At the moment, the progress is limited, and we are stepping that up to try and get an increase in delivery as we progress. The supplementary staffing breakdown here, this is just for the partnership. So comparing that to the same time frame for 2023-2024, the costs reduced by just over £500,000, but we are still seeing spend there of almost 5.4 million, and that's set against an overspend within staff costs within the partnership of just over £1 million. And we can see here just the profile of spend across the first 3 months of the year. So quite a big reduction in month 3, which we are hoping to see sustained as we go into month 4. The subjective analysis, it's just a breakdown across the various cost categories, just to highlight that we are seeing some pressures across most of the areas. The general non-pay is the only one really that's shown any significant underspend at the moment. And I will stop there, but happy to take any questions. Excuse me.
Thank you very much, Elaine, for that. Have you got any indication you can give us, even at a high level, on where you think the position has moved from month 3 into month 4? We won't hold you to any numbers.
At the moment, we're seeing a deterioration within adult social care for about 2 million, but that is, I suppose, we're mitigating that by the assumption that we're going to be able to deliver a break-even position within adult social care. Overall, it's pretty static, to be honest. The drugs and prescribing is still a concern, because we're not seeing, the only movement that we're seeing on that is upwards, and that's been reflected across all the board areas at the moment, unfortunately. So it is a fairly static position. There's a number of things that we are trying to deal with from the operational side that will have an impact on the financial side, but I think it'll be into month 5, month 6 before we actually start to see those coming through. And at the moment, it does feel as if that position is likely to deteriorate unless there's any additional funding comes with that activity that we've been asked to undertake.
Thank you, Elaine. Before I throw open to questions from committee members, I wonder if I might just ask Pam, Elaine, Arlene, just to give us an overview of the work that's ongoing in relation to the learning disability spend, and how we're using the findings of the internal audit report to influence that work. I appreciate, Elaine, that you'll bring back some more detail to the next meeting, but it'd be interesting to give some context to the action that Pam has helpfully outlined in the later piece. I don't know who wants to kick off. Who wants to grab that particular nettle?
Arlene, are you ready to come in on that point? Thank you.
Yeah, certainly. So what we've done is we've been consolidating the information that we've got from the audit report in with the that need in order to reach financial balance. And so we're in a consolidation phase around about just what are we going to build. So I had a meeting on Friday. In fact, I spent the whole afternoon on Friday with a whiteboard building exactly what those work streams will be and how, because what's crucial is that we work in partnership with our independent sector, because most of this delivery and most of the spend is commission spend rather than in-house spend. So there's a difference there than perhaps what we're doing around about care homes or care at home work, where much of that is in-house. So we've just been building that, and Ruth and I would expect to have something by the end of this week, middle of next week, that will shape all that. There is obviously lots of ongoing conversations through contract monitoring, through reviewing processes, alongside the reviewing team for every single package of care and whether that can be delivered differently, alongside additional work with the SDS programme board, which Ian reports into this meeting on a regular basis around about building up the support that communities can offer people with a learning disability. Paid support should only be one element of people's care. It shouldn't be all paid care. And how do we work with partners to build up those? So not in a coherent form that I can give you in a table about this is what we're doing right here, right now, but that is coming together. But there is a lot of work ongoing.
Thank you very much indeed, Ali. I think it's always just useful to get that context for an internal audit report. Not everybody is aware of the detail, and actually that this report, and we will touch on it later on in the agenda, but it is live, and we're actually using it to influence what we're going to be doing going forward. Pam, and then I'll open it up to questions.
Thanks. And just on the governance aspect, then we are undertaking the work to review the ACAG, the Adult Care Advisory Allocation Group terms of reference, just to make sure that our discussions and decision making and financial governance and service plans are aligned in a more robust governance function as part of the response to the audit as well.
Thank you very much, Pam. I'll now throw it open to general questions on the financial position, and I've got Muriel.
Thank you for the report, in tough times indeed. Where do facilities sit in this? The estates, the building estates and repairs, whether they're due to age or whatever. Obviously, we've inherited a couple of homes from private sector as well, and I'm not entirely sure what state of repair they were in. So is that does that cause additionality in costs, or is that factored in?
I can come into that one, Jerry. So it depends what type of work's been undertaken, Muriel. So we've got revenue costs, which are around the day-to-day maintenance, and the capital ones are around the bigger, more structural changes. So there was elements of both in both mains and in Home Farm, but with the costs of the actual building, Highland Council actually cover those costs. So they cover the capital costs. And there's also an element of funding sitting within the adult social care budget that transferred from Highland Council at integration for property costs, so they're covered. But what we have seen is with both homes, in order that we got registration, there was a significant amount of work required to bring them up to a standard that was acceptable.
Councillor Birt.
Thank you. May I ask an incredibly naive question from someone who is totally clueless about financial matters, let alone matters in the health service? When one's dealing with massive overspends in nearly all areas, when you get towards the end of the year and everything in the budget that was set aside is spent, where does the extra money come from to pay staff on all the other bills, etc.? I say, obviously very naive, but I don't understand what happens.
It's actually a really good question, and it's one that we've asked the same question of Scottish Government, because we've never been in a position Scotland-wide where all boards are experiencing the financial challenge that we have. Normally there's an element of brokerage that is provided to allow all boards to deliver a break-even position. What we are being told is that the funds will be available for us to continue as boards, so that the finances will be covered. But if we are overspending in excess for brokerage cap, which is the 28.4 million, it will be shown as an overspend, and that's not a position that we have been in, because any time up until now, any gap has been covered by brokerage. So we're not in a position where we get to month 10, 11 or 12 and we're not going to be able to pay staff. We do have the coverage from Scottish Government to actually fund that, but we're not sure what the impact will be as we move into 25, 26. But we know that for this year we will have the cash to cover our expenditure. It's just how that's recorded for audit purposes.
All sounds very dicey. Yes, I see.
Yeah, I think it's
above board.
Yeah, I think what we don't report on at a committee level, Councillor Birt, the health board, although it's not one of its formal targets, also has a cash requirement. And it's as Elaine has outlined, it's normally linked to your revenue resource limit and your cash requirements. And I think, and we asked the question at the last Finance and Performance Committee in terms of have we got that formal coverage. So although we might overspend, Scottish Government will ensure that we have sufficient cash in the bank to allow us if you in effect trade on a day-to-day basis. I think as Elaine has indicated, the clever bit is going to be how we reflect that in our year-end annual accounts when we have a brokerage limit of X and actually have a cash requirement that's considerably higher than that. But we will always have the physical cash to pay our bills, to pay our salaries. That's not going to be a problem. But it is actually a really good question.
What is the definition of brokerage in this context?
Do you want to go, Elaine?
Yeah, and I suppose because we're not getting brokerage to cover the full amount, it's a strange one, but it's additional financial support from Scottish Government to deliver an improved financial position.
In very simple terms, Councillor, but it's a short-term loan from Scottish Government, and brokerage is always repayable. That's the problem. And the theory being, once you get back into financial balance, you will then begin a series of repayments so it's brokerage in the terms of, it's just not an additional allocation, it's brokerage in the terms of there is an expectation you will repay it at some point in the future. I've now got Anne.
Okay, thanks, Jerry. So I suppose I've got a number of points all around a similar sort of theme, Elaine, related to the adult social care position. That figure that you mentioned in terms of a deterioration in month 4 for adult social care was quite alarming, really. Do we know exactly my first question is, do we know what's influenced that deterioration?
It's an increase in the packages and the cost of some of the packages within learning disabilities is one area, but we're also seeing the payments that we're providing for our care at home payments are actually increasing as well. So where we've seen provision actually coming back in-house and we're providing a service in-house, what we haven't actually seen is that corresponding reduction in our external providers' care at home costs. So we're working through everything at the moment, just doing that almost line by line comparison to see where we are compared to the plan that we set. The figures that were into the plan were based in October last year. So just to see what's actually moved. I think the issue with the quantum is perhaps masking the deterioration through months 1 to 3, but now that we've got that agreed, we can see exactly what's coming through in the funding, and we're now tracking the spend to see where the increases are coming through. But we know that we do have pressures within learning disabilities, care at home specifically, where we've moved from the independent sector to in-house provision, and also some of the payments that we're providing to suppliers around sustainability as well.
Okay, thank you. So I'm not sure if I picked you up correctly there. Does that mean that the information in this report is updated in relation to the quantum? Is that now agreed?
It isn't in this one. We've only agreed that at the beginning of month 4, so it's reflected in month 4.
Okay, and we were hoping that would improve the position. Is it clear whether it has done or not?
It has, but it hasn't improved it by as much as we would have expected it to improve.
Okay, thanks. So my second question is around the value and deficiency reduction programmes. I may have got this completely wrong, but am I correct that at the moment the total forecasted to be achieved in North Highland by year end is 1,774,000? Is that correct? Is that just health, that figure? So the adult social care is totally separate. I suppose that's what I was trying to get at.
Yeah, adult social care is separately. So the value and efficiency target for adult social care is 5.7, and what we're reporting at the moment for health is the 1.774.
Okay, so I suppose what I'm thinking is that a little more detail about some of these would situations would be helpful. So, for example, you've said that our plan is still very much based on an assumption that the adult social care budget will achieve balance. Given what we've heard about the deterioration and about the quantum, I suppose I'm becoming increasingly doubtful whether that assumption is evidence-based. And in relation to the value and efficiency programme, which is also very relevant here, I'm just wondering what is the current value attached to plans that we think is credible for adult social care. I wasn't sure I could work that out from the information here. So here and now, what is the value of the savings from adult social care that we currently think it's credible that we will deliver in year? Can anybody tell me that?
Yeah, so based on where we are at this moment, or where we were when we did the monthly reports, we were looking at 3.7 that we had confidence in delivering. However, given where we currently are with the work that's ongoing around the 90-day plan, which I know Pam's going to speak about later, there is the potential that won't now be achievable. And we're working through that as we're doing the work on the 90-day plan.
Okay. Okay, so I mean, I absolutely understand just how difficult this situation is and how difficult it must be for staff to come up with plans for savings, especially within the context of what we're hearing about costs of packages increasing, etc., etc. So this is not in any way intended to mean that I don't think people are trying their absolute best and hardest to influence the situation. But I suppose I am beginning to question, from a governance transparency point of view, at least whether we need to be in some way, showing the level of risk around the delivery of some of these plans and a break-even position for adult social care. I mean, that's just how I see it, Elena. I mean, and it may be that you can give me comfort that we are still presenting the situation in a transparent way, but I suppose that's one of my concerns at the moment. But as I say, that's not to suggest that anybody is doing anything wrong or not trying their best to deliver here. But I guess the general message is that we're not making as much progress as we had hoped, as quickly as we had hoped, and there are increasing pressures pointing in the opposite direction for us. So, it seems like it's getting even harder than it was at the start, than it appeared at the start of the year. So I guess that I'm wondering whether we could get a bit more detail specifically about progress in future reports, not today, obviously, about progress with the specific savings plans, and just a general sort of question, I suppose, about how we're presenting the level of risk around the adult social care position. Okay, thank you.
Yeah, we'll bring that detail back on the plan.
Yeah, I think, thank you very much for that. And I've written down similar comments. I think I'll have a chat with Pam after today's meeting, and maybe also with Elaine. I think in our next finance report, which will probably take us up possibly month 4, maybe if depending on dates, month 5, but more likely month 4. I think we do need to just develop our level of understanding of how things are moving away in either direction, positively or negatively, from our original planning assumptions, which we all signed up to. There's no that's where we are, and just get that level of detail and understand the key risk areas. And I've written down the learning disability spend, the care at home spend, the adult social care savings, movements on the quantum, just so we see what that does to us all in terms of a projected year-end position. So I'll speak to Pam and Elaine outside of the meeting, and we'll bring that in, I think, to the next finance report, and then we can consider whether we need it on an ongoing basis or whether we're just amending where we're likely to be. Pam, I see you've got your hand up.
Thanks, and I just thought it would be helpful just to reflect that, you know, in terms of the risks and the kind of financial performance, you know, that goes through financial and performance committee in line with the audits, you know, in terms of the complex care packages or adult social care, you know, that's overseen by the audit committee. So I guess we just need closer alignment to bring back assurance to this committee of the broader issues, you know, where they might be taken forward in other committees, but actually providing that information and that risk plan for the specifics in this committee. So yes, Jerry, we can have a discussion, and I'll make sure that we marry that up for the next meeting, so that we don't think that things are sitting in other committees, that we actually do provide the oversight for this committee. Thanks.
Thank you very much, Pam. Diane, I see your hand there. We can't hear you, Diane. Nope. You're still silent, Diane. I don't know if your microphone, it's not off. I don't know if it's turned down. It's on.
Sometimes, Diane, if you go out and come back in again, it helps if you have a problem like this. You could try that, or put your question in the chat if you want to put your question in the chat.
Okay, we'll wait. We'll see if a question appears in the chat, and we'll maybe just summarise. So I think what Elaine has outlined to us is was an already challenging financial position. It probably grows more challenging by the day. And we don't know if the impact of the Cabinet Secretary's statement yesterday will have any impact on us yet. It's far too early to tell on that. I've got no doubt Elaine and Highland and others are working through the details of that with Scottish Government colleagues. And by that I mean probably means in terms of allocations, which will be anticipated that may not now come in, or may well come in at a lesser value. But I think we have to assume that we've got a very challenging financial position. So I'm just going to have a look at Diane's question, which has popped in there. And I think what Diane is really looking for is some maybe some detail on what actions has actually been taken in relation to the supplementary staffing costs, and probably across, and I know it's alluded to in several papers, but maybe Pam, if you could actually just give us an overview of the different streams of work that are ongoing to look at the use of supplementary staffing.
So workforce is a significant challenge for us in terms of workforce availability and you know, low unemployment in the Highland in competition with other sectors. So, you know, we know that very well. The specific impacts we have is that you know, we're unable to staff our current capacity. We have to bring in agency staff. So we've done a number of mitigations around making sure that we use agreed agencies and not just, you know, apply individual prices to individuals or individual agencies by preference. So there's really good governance wrapped around that. We've also done quite a lot of value and efficiency work streams just around making sure that we use bank staff availability first, for example, before more expensive agency staff or overtime. We've done some really good specific work that Arlene might be able to talk to if we've got a couple of minutes around mental health services, just in terms of where we had people needing extra observations, and obviously that was maybe needing to bring in high agency costs, so managing to work with different people in the workforce, for example, nurses who are in student training, so getting them onto the bank, making sure that we make the best use of people and that we develop them at the same time, which has been really advantageous. We have had a lot of capacity issues in terms of staffing what we can. So, we're working broadly across health and social care with all our partners and, all of our skills to try and bring people in. We had good recruitment with the reserves, making sure that people could work more flexibly for us. So not just saying that you have to come and do shift work, that you could work from 2 to 5 on a Friday if that's the only hours you had available in the week, or if you had a partner or a spouse or a family member that worked offshore and then you wanted to swap around and maybe provide more hours over a week or a fortnight, and to fit in with those types of work-life balances. We've been trying very hard to make sure that where we can recruit, that we recruit into vacancies and vacant capacity, so that we can maximise the best use of our workforce. Arlene, do you want to say something very quickly, just the headlines around what we've achieved in terms of value and efficiency within mental health and learning disabilities? Thank you.
Yes, certainly, Pam. So I think, as Pam suggested, a number of different measures have contributed to our reduction of use of supplementary staffing. One is our increasing observation practice within the hospital, so different ways of observing individuals so that you require less staff in the first place. The other part is about kind of really ramping up our recruitment. So we have we took on, I think it was 6 international recruits into the workforce within New Craig. So therefore, if you've got more staff, substantive staff, you require less agency staffing and therefore less cost. We also did a recruitment for the bank, which was hugely successful from a healthcare support worker perspective, and we are hopeful actually will eliminate all of our usage of agency support workers from the perspective of New Craigs. We implemented a number of additional measures around about grip and control, and we what we call check and challenge daily meetings about when you're asking for agency staffing, is that actually the teams are challenging each other about, is there an alternative way to do this within the hospital resource, as opposed to perhaps previously where people would just have thought about it about a ward resources, that we're starting to look a bit broader about what availability resources we have. And eRosters has also assisted with that process to make sure that we've got the staff that we require in the place that we need. The next step is that we still we've shifted quite significantly down from our use of agency usage. What we're now needing to do is that we will still need to reduce the numbers of supplementary staffing that are required because of patient demand. And so we're looking at whether we can do some workforce establishment reviews, which would better reflect what the needs are of patients that we have now within the ward setting, and can we do more work around about the improving observation practices, and how do we engage with patients on a day-to-day basis. We are also having conversations on the edge around about using volunteers within New Craigs. That's unlikely to impact on the number of staff that we require because of the kind of levels of illness. Obviously, it's an acute mental health hospital, but maybe in the dementia wards, there may be some elements where if people are actively engaged, that may help reduce some of the increased observations that people require. So a number of different work streams ongoing, which have brought this down.
Thank you very much for that, Arlene and Pam. That was a good update there. Hopefully you caught all of that, Diane. Thank you very much. Okay, I'll bring that discussion to an end. I think we as a committee, we recognise a very challenging financial position in a year ahead of us, which we knew about at the beginning of the year, and we will pick up for the next report in terms of some more detail to bring to the committee. So just looking at the recommendations, we're asked to discuss and note the financial position at month 3 and associated mitigating actions, and accept limited assurance. Are we content to do so? Okay, seen some thumbs and some nods there. Thank you very much for that. Thank you very much indeed, Elaine. We'll move on to item 3.1 in the agenda, Primary Care Improvement Plan Assurance Report. It's got Jill's name on the report, but I'm not sure Jill is with us, Pam.
No, Jill's actually not with us today. She's on leave. And normally we would ask our very competent primary care managers to come along and support with the presentation of the paper, but I'm afraid Katrina isn't available this week. So I'm going to do a fill-in and just give an overview
Okay.
of the paper. And Claire Copeland's with us today as well. So we'll try as best as we can to manage some of the questions in the absence of the experts. But it's largely an assurance report around the progress achieved on our PCIF project. And the report covers the period up to the 31st of August. So there's been a set out of how we've used the primary care fund, some of the developments that we've been undertaking, where we've experienced some of the spend, but also if we think about the pharmacotherapy one, you know, where we have you know, good employment of trainee pharmacy technicians, etc., you know, to enable us to deliver more robustly going forward. So that fits in nicely just with the previous conversation around workforce. There's been quite good staffing achieved in our first contact physiotherapy. We don't have, you know, Highland-wide robust recruitment, but we're moving towards that in terms of our workforce. The community link worker, the contract retendering process is complete. So that's been a very good and focused piece of work. And the community link worker year 2 annual report is drafted, so we'll be able to look at that in due course in terms of the outcomes for people and how we've been managing social prescribing and the benefits that have had in terms of our overall strategy for you know, our mental health and our primary care delivery. We've got the vaccination transformation programme. We've been undertaking a number of vaccination improvements and looking at option appraisal. So we've got a specific paper of that within the committee meeting. We've been developing our community care and treatment options in terms of our Highland-wide services. And we've been doing quite a bit of work on premises and going back to earlier issues that were raised in the finance section. You know, we still have significant work to do around primary care premises and leases and making sure that our primary care premises going forward are robust and fit for the population to meet their needs. So moderate assurance is provided in terms of the content of the report, in terms of the developments and the funding and costing piece. So I will stop there and open it up for any questions. Thank you.
Claire, I see you've got your hand in there. I don't know if you have a question or maybe just something you want to supplement some of Pam's remarks.
Yeah, it was just, I suppose, just to highlight a couple of wee things. I mean, it's been a busy time in the primary care world. You've got a paper coming on vaccinations. It was to draw attention to the CTAC as well. We'd taken an options appraisal proposal last year. We felt for North Highland in particular that it wasn't going to meet the needs of practices. So we'd had early conversations with Scottish Government colleagues. So the work that we've taken, some of the learning from that into the vaccination work as well. And I know that's sitting separate, so I'm not going to go into that in any great detail. But it was just to highlight that. And also the second part was that we've started some early planning around what a primary care strategy would look like. So again, we're sort of thinking and trying to have an eye to the future in terms of where this primary care improvement work has been, and also thoughtful of what the next phase of the contract may or may not look like. We also need to think about, from a Highland perspective, what primary care from a strategic perspective looks like as well. So we've started some early work on that, which I thought would be useful for a committee to know about. Thanks.
Thank you very much, Claire. I'll throw it open to questions. Christopher.
Thank you. thanks for the report. In paragraph 2.2, the third sentence, it reads, non-expert medical generalist workload needs to be redistributed to the wider primary care multidisciplinary team, etc., etc. I just wonder who these non-expert medical generalists are. Could you please enlighten me?
I believe that would be, and I see Neil is on the call as well, but the GPs are the expert generalists in this part, and I'm not sure if there has been a minor error in the typing of it, but it's a blend of GPs and supported by people bringing their expertise, like physio, pharmacy, etc. I will get that point of clarity for you, Councillor.
They're all experts in their own fields, aren't they?
Indeed, and I'm trying
and
to...
this talks about non-expert generalists.
Indeed, you make a very good point, so leave it with me. I will go back and we'll get, if there's been a minor typo, we'll get that rectified, because you make an excellent point.
Thank you, Christopher. I think I would tend to agree with Claire here, that I think there's been a typo here, that the intention is to divert work away from GPs, recognising that they have particular skills, to other experts with particular skills who might better be.
I thought it might be referring to physician associates, about which there is a major political row, but it's not. You say it's not that.
No,
it's not that.
That's a whole other topic.
I think Claire and Pam will take that away, because I think it would be important that we get that. I wouldn't want any of our colleagues to think that we're undervaluing the enormous skill base which is actually contained within those 6 or 7 bullet points. Thank you very much for that, for picking that up, Christopher, because I have to be honest, I missed it as well. And I'll throw the next one over to you.
Thanks, Jerry. So a couple of things. I was wondering whether somebody, I suspect, like me, a number of the non-staff members of the committee find understanding what CTAC is all about quite tricky. So I was wondering if somebody could say a little bit more about what that is all supposed to be doing, and what and whether we feel we're moving towards a proposal that will be accepted by Scottish Government. Just what progress are we making there? I was very pleased to hear Claire mention the work on towards a primary care strategy, because in some senses, that should be setting a wider context for a lot of this work. So that's great to hear. But I just wondered, I mean, I'm assuming that will take some time to come to fruition, because there'll be quite a lot of work involved in that. And in the meantime, I just wondered where we felt we're at in terms of stability of our GP practices and delivery from them. There's been a number of media reports recently about practices closing their list. We have talked a number of times about the fragility of GP services. Some of our demographics, especially around Inverness, are changing probably quite significantly. So I just wondered what our assessment was of, whether or not we're likely to soon see some more movement there in terms of asking us to take on 2C practices, or whether we think things are fairly stable for the moment. Thanks.
So could we pick that up therefore in two parts, Claire, before you come in? Can we maybe just deal with what is CTAC, for those of us who are not familiar with all the jargon and the phrases and haven't been doing this for a few years, and then maybe pick up that wider, between yourself and Pam, that wider contextual piece about primary care and its status at the moment in terms of fragility or hopefully stability, and moving forward. Thank you.
Yeah, no problem. I saw Neil had his hand up, right? So I am not the expert in CTAC. I'm not going to pretend to be. Neil is your man for that. I can tell you my understanding of it, but if you want an in-depth, what community treatment and care and practice nurses, etc., all do, Neil's your man. So respectfully, Neil, do you mind picking that one up and then I'll come back? Is that all right? You'll be far more credible than me.
That's why I put my hand up in the first place. But yeah, I mean, long and short of CTAC is essentially some of the things that are done currently by practice nurses and healthcare assistants in practice. So this would be, for example, taking bloods, phlebotomy. So rather than having to actually take it in here with the patient, I can spend more time discussing, analysing, diagnosing, etc., planning, and the phlebotomy can be done by colleagues, and the idea was to move that out, which is the system, for instance, most places that I'm aware of in England. So that's one thing. It may be things like wound care. So there's quite a bit of history in that. Chronic wound care, long-term wound care used to be done mainly by district nurses, but with the contraction of district nursing resources a decade or more ago, a lot was actually taken on by practice. It moved back to practices, and the idea again to move that bit of workload out, and the idea to free up practice nurse time so that we could then, with increasing sort of education, our in-house staff would then take on roles, say chronic disease management roles, including decision making, which is currently done by the GPs at a certain level with oversight. That said, given our geography, there is a general feeling now that CTAC probably, or the concepts or those services, those necessary requirements for patients are probably certainly outside of urban centres, best kept in-house, in practice, with movement of resource to practices. This was mooted by colleagues in LMC GP Sub way back in 2018, but at that point in time, the political field would not allow consideration of that. So now things have changed, things have moved, people are becoming a little bit more flexible, and I think that the options appraisals will probably go in that direction. And I think it very much is, and we'll come back to it time and time again, it very much reflects our geography. So if you're working in a city, it makes great sense to have a phlebotomy centre just down the road that's separate. It can run to scale, it can be efficient, it can be very cost efficient. But it doesn't really work for Gairloch. And that's what it comes down to. So it's those sorts of activities will be covered by CTAC. Trying to think of something else I was going to ask in there. I think Claire will probably come back to stability and things like that. I'm just going to chip in a note. I'm aware that in Argyll and Bute, the integration authority there is looking, or the oversight of primary care there is looking to move 2C practices out to GMS practices and is offering them as potential GMS practices. And I would just say it would be interesting to see how that goes, because if they're picked up as partnerships, that would reflect certainly an improvement in the situation, in stability. I know I've mentioned stability before, and I think it's really, really important that running as we do on this small business model, that we do have stability of incomes to be able to employ staff on a long-term basis and to plan for the future. And that certainly is the way to go. Primary care strategy, my final question, sorry to chuck in a question as well, is who's involved in developing the strategy? So hope that helps.
Thank you very much indeed, Neil. That has actually been very, very helpful. Claire, before you move on, I see Councillor Burt has put a question in the chat in terms of the the acronyms which we're using in terms of CTAC and HSCP and all of that. I wonder, just as a general, for all our future papers, can we just make sure we try and limit the number of them? I know when you live and breathe this stuff, it becomes very easy, and I'm very guilty of it myself, to slip into that acronym speak. But what we'll do is I'll get Stephen after this meeting, Councillor, but really just to expand all the acronyms and get it sent round to everyone, so you've got a little glossary there. But I'll maybe ask Claire now just to take us a little bit further forward in terms of that, our strategic thinking in primary care and where it might go and what we might think about. Thank you.
Yeah, acronyms, yeah, they frustrate me as well, actually. So it's again an excellent point to highlight. A few things, just sort of trying to keep the flow of the different bits and pieces in relation to CTAC, the options appraisal. Just for a little bit more information, Jill, myself, had meetings with Scottish Government colleagues over the sort of May-June time, and there was I would say a shift in terms of the thinking. Neil's mentioned the word flexibility, and that's something, again, I don't want to veer off piste into vaccinations, but flexibility is a key word in that, and they seem to be more understanding around about our remote and rural practices in relation to CTAC as well. So we were quite encouraged by that. They gave us some really useful feedback about how to further develop what the options appraisal will be, and what that will look like. So it's a kind of watch this space. Of course, we're kind of running a few things at the minute within primary care, so we'll bring an update back around options, CTAC options appraisal specific, once we've got that feedback, the next stage of feedback. In terms of primary care strategy, we've had literally 2 meetings. GP Sub have been involved in that, and as have our pharmacy, dental, also an optometry, because primary care is general practice, and all our other independent contractors. And it was really a bit of a kind of scoping discussion, I would say, around about kind of July time. There were a few other folks, by the way, in the room, and I'm quite happy to share with that. But the upshot of it was, what we decided to do was spend a wee bit of time over the next month doing what we were calling a needs assessment, and it was working closely with public health colleagues to really understand what is it that we're trying to deliver for our populations. I think also, and Pam's talked about this before, in terms of what's going on at locality level, in terms of how we're shaping and redesigning services there. So we're doing it, I don't want to say the word slowly, because that makes it sound like, but we're doing it diligently and really taking our time to understand what it is. And public health is going to be key to that. Then once we've got that information, we'll bring folks back in the room. And again, I'm happy to send a little bit more of a detailed update, but it's very early days, and I think it's the right thing to spend the time getting all the information for it. The other bit in terms of sustainability for 2C practices, if Jill was here, she'd talk in a lot more detail around what we've been trying to do in North Highland around testing the market, in terms of what Neil's referenced there about practices going back out to tender and out to GMS. There was a question asked actually from a clinical governance committee, I believe, coming up this week or for next month, on a variation on a theme actually around about risk, sustainability, etc. And I just wonder for committee, rather than hearing a lot of bitty information from me, because I could talk a wee bit about, we've got positive stuff that's been happening in Alness and Gordon in terms of their stability and recruitment, slightly more precarious picture elsewhere on the patch, I would say. I wonder if it would be more helpful if I could combine an update that would meet the needs of clinical governance committee as well as yourselves, that talks to that wider primary care sustainability. Sorry, that's a question and a response to a question. I do recognise that, but I'm sort of speaking slightly on the hoof as well. And I just think, given the importance of it, you might actually want something a wee bit more robust than my kind of chippy anecdotes, if you like. Pardon the language.
No, thank you very much indeed, Claire. That's helpful. I think I was going to have a discussion with Pam outside of the meeting. I think at the appropriate time we would be looking probably for a substantial, I'll use the word substantial paper on primary care strategy. Not so much, because I totally agree with you. This is this is a do it right rather than do it quickly sort of discussion. But we'd be looking for the key themes and the key areas and how we're going to move that forward, and actually how we're going. What we'd be very interested in is how we're going to engage with GP colleagues, but actually how we're going to get the views of the public as well. What do they want from a primary care service? And as you say, all aspects of primary care, which makes it a pretty big service. I'm not seeing any other. Anne, I just saw your hand go back up there. I'd seen it and then it disappeared. So I'll let Anne bring this item to a close.
So I think that would be very helpful, Claire. You know, certainly, you know, if you think there's a number of pieces of work that are relevant going on, then better to look at them all in a one, or rather, and for both committees rather than trying to do something on the hoof. So that would be good, at some point. I think you mentioned in passing phase 2 of the contract changes. Did I pick that up correctly? If you did, then could you just briefly say what phase 2 would be intended to bring about further beyond what we've already done?
What I was referring to was we have a change in personnel and I'll use an acronym, but I'll explain. So SGPC, which is the negotiating arm of the BMA, the British Medical Association, with Scottish Government colleagues around about what the next phase of the contract will look like. So relevant to Highland, one of our local GPs is going to be the new vice chair of that. And so I won't go over the history, and I'm sure Neil can also. You'll all be aware of Highland's views on the 2018 contract. And so I was referencing it in highlighting that there may be more changes, but those changes are uncertain at the minute, given we've just had literally a couple of weeks ago a change in personnel from the people who brought you the first contract versus what it may or may not look like. So it was a bit of a heads up, and I'm just delicately backing away from that one just now.
Okay, all right, okay. I'll leave it there then. It sounds like it's the best thing to do.
Yes, we'll get ourselves into trouble if we get the crystal ball out and try and forecast what may or may not happen in terms of the GMS contract. So thank you very much. I think that was an excellent discussion. So we've been asked as a committee to note the report and accept moderate assurance, and I'm taking that the moderate assurance is just based on the CTAC discussions and the need just to bring them to a conclusion, and possibly where we are in vaccines, which I know we're going to come back to. But I think there's good progress across the other elements of that primary care improvement report. Are we happy to accept that moderate assurance? Yep, seeing thumbs up. Thank you very much to Pam and Claire. Very able substitutes. I shall pass that on to Jill. Okay, we are going to move on to 3.2, the Highland Drug and Alcohol Recovery Service Report. And I think we are being joined by Teresa. If I open up another screen.
I'm here.
Teresa's with us. Teresa, you weren't with us at the start. Everybody did. Oh, you were. So you heard my.
Yeah, I could see you all.
You heard my. Everybody did is a great favour this month and got his papers out in plenty of time. So we've read and digested. So really, if you just keep yourself to the key points and leave maximum time for the committee to just have a discussion, and I'll just hand over to yourself.
Thank you very much, Jerry.
Yep.
I've heard people say Jerry, so yeah.
That's me.
And thanks. I just want to say thanks for inviting me back. I can't believe it's over a year since I've been here. And I suppose just to highlight, before I highlight the key points, the purpose of this report is to provide assurance. And in order to do that, I'm going to be sharing some of the statistics, both in relation to progress, but actually also in relation to individuals who have died in NHS Highland. And I know I don't have to say this, but I am going to say it because I can never underestimate or not say it, is that actually behind every number is a person. And I just wanted to acknowledge that in this forum. There's a person that's died tragically, prematurely, and they've left behind a family and a community who's absolutely devastated by the loss. So I'm aware of that. I know you are aware of that. I just want to acknowledge it. I'm able to show you some progress, as you'll see from the stats, but it's not enough. It's not enough. And despite whatever commitments in this paper, I also want to give a commitment that both myself and the dedicated workforce and the teams that we work with are absolutely committed to doing everything we can to actually reduce the harms that we've got related to substance use in our communities. So that's my kind of introduction. You've got the paper in front of you, I assume. So you will see that actually since the last year, in relation to what DARS does and how DARS monitors its progress, not much has changed. We have our progress is monitored against the sort of 3-week referral to treatment time targets, which has been in place since 2011. And we also have our medication assisted treatment standards. There's 10 standards there, which we're also monitored against. And MAT 1 in our treatment standards is about that same day assessment and commencing treatment where it's clinically appropriate to do so. So there's lots of graphs in this. You will see our national benchmarking report, and since last year, the national benchmark for 1 to 10 for MAT is reporting green or provisional green for all 10 MAT standards. That's in relation to process. So we have processes in place across Highland that we could deliver MAT. We were benchmarked slightly different this year as compared to previous year's national benchmarking reports, where they have looked at experiential data, numerical data, as well as process. But this year's process, it's process. So there has been a consistent progress since 2022, and you'll see that from the charts. I've shared our treatment time standards, which is about our 3-week. 90% of people will wait no longer than 3 weeks to access treatment and recovery for substance use. I have said view that with caution. This wasn't the sense on the ground, what we were feeling, and we did a bit of it looked like we were doing absolutely fantastic, yet practitioners were saying, actually, we've got waiting lists building, and we've got various different challenges. So we did a bit of a deep dive, and we identified some process recording errors. We've now rectified that, and we've also already begun work, or we had anyway, beginning work to address some of the challenges we have with increased demand but reduced capacity within the service. So we've done a lot of work. So you will see a bit of a dip in performance, but then you will also see an improvement, a climb again at the next reports if they haven't been released yet. So just to highlight that to you. You will see this is where we have some stats about harm. The stats in relation to people who have died because of alcohol is reported from 2022. These stats are outdated. We're expecting a further report in September this year. Sadly, there was 66 people who did lose their lives, and that's been coded directly related to alcohol in 2022. And it's a little bit higher, but not significantly higher than the Scottish average. In relation to drug-related deaths, last month we saw the National Records of Scotland publication, which nationally reported an increase of 12% in drug-related deaths across Scotland. Within Highland, we had a reduction of people who died and were coded as somebody who had a drug-related death. We had last year there was 42 deaths. This year there was a decrease of 16, which is simply 38% decrease of people who were coded as dying from a drug-related death. Out of those people who died, there was 5 of those people were classed as intentional self-poisoning. So not within this report, but I just wanted to highlight. We have asked for a bit of a deep dive into that data in more detail to inform some of the work we have in relation to the interface between substance use and mental health. So if we really understand what went wrong, what could we do differently so that we can reduce harms in that area. So that work's ongoing. You know, as I said, it's a difficult position. We can see that there's still a lot to do, and we're doing everything we can. It's a really fragile position, and it could tip and go the other way again. But we're doing everything. We're continuing to evolve in whatever way we can to try and reduce the harm. I've shared some of the work and some of the evidence that supports the work that I'm sharing with you. We're increasing our naloxone distribution year on year. You will see that, and we're expecting that will increase this year as well. And that has a huge factor in reducing overdoses and deaths related to opiates. So that will continue. The downside of that is the budget we have allocated to that is not quite enough. So we need to kind of look at how we can fund that, because that has a huge impact. You will see we have shared some initial qualitative data about a health inequalities project that we've had, a 6-month project that we had targeting the most vulnerable in our communities, those rough sleepers, often mental health, drug and alcohol problems. That has been formally evaluated at the moment. The sort of qualitative data is really supportive of it, but I look forward to being able to share the more quantitative data of the outcomes for the people who have accessed that service when it comes available. And we continue to focus on our MAT. By focusing on our MAT, we're also focusing on alcohol use. You will see some more initiatives that we've done and why we've done it. You'll see that 24% of people who die from a drug-related death were in custody in the 6 months prior to their death. So we've really focused in on there. And as you can see from the data that I've shared with you, we are managing to reach some people who have never been known to service before, and offer that health improvement, harm reduction interventions at the point of them being in custody. We've also rolled that out within prisons, and this MAT Pact, as it's called, has received national recognition. It's in the National Justice Toolkit now, which is a great achievement for Highland. And it also won an award at the National Mental Health Nursing Conference. So it's really on the map, really innovative, and it's good to see. Same goes for Caithness. They've got a very similar approach in a remote and rural setting with their trigger checklist. And on the back of the trigger checklist, they've also just been recently successful in getting 40,000, to test this and put this into a remote and rural general hospital in Caithness. So again, it's a research, and we will look at the impact of how that works in remote and rural settings. Our assertive outreach teams continue to pick up non-fatal overdose in anybody who's identified, and that work continues. The biggest challenges has been within our drug and alcohol recovery services. Lots of vacancies and reasons behind. I mean, lots of things that have impacted on us being able to recruit timely and what's required. That's kind of led to staff shortages in 2 areas, which was Osprey House and Rossshire, really big waiting lists. We've undertaken a bit of an improvement work to try and really dig down into our waiting lists, and you will see from the outcomes that actually not a lot of people were dependent, and needs could only be met by drug and alcohol recovery services. So every person on waiting lists were contacted, their needs were explored in more details, and for quite a lot of them that involved signposting to our third sector agencies and to our harm reduction service and the other groups that we've got available. This has worked really well. And we would be keen to develop this further, because we're seeing more numbers coming into service and we don't have additional resource. So we have to think about how we do things differently longer term. Obviously, that's going to be dependent on other services being in place to support people who are non-dependent or problematic, who are worried about substance use or alcohol use or whatever. So that's in more detail. We continue to review our residential rehab pathway, that's back on track. There was a bit of a delay with that, but we've got that back on track with the support of our ADP, or Highland Alcohol and Drug Partnership. So I've given you within the report there, I've offered a moderate assurance, assurance that we are complying with our national drug and alcohol related policy. There's more detail about why that's moderate and some of the challenges, but I'm going to stop there and breathe and see whether anybody has any questions or queries or information, that feedback. Thank you.
Thank you very much indeed, Teresa. An excellent report, and thank you for your introduction to it. Just to let everyone collect their thoughts, I see Tim's with us now. I wonder if Tim, if you've got any supplementary information that you might be able to share with us in terms that might complement the report in terms of Highland ADP and its current thinking. We're obviously considering the DARS service today, but obviously, as Teresa has outlined in the report, highlights interaction with the Highland ADP is absolutely critical in this, and just give us an idea of current thinking and current plans within the ADP. That might be helpful.
Yeah, and sorry for my late arrival.
No, certainly not.
Yes, I think probably the most important thing in terms of alcohol and drugs regarding the ADP, in addition to what's been put in the paper, is the wider approach to the harm from alcohol and drugs, and the need to look broadly at different levels, and at when we might look at society and younger people, like in the work that's been done in several secondary schools with Planet Youth, or look for, let's say, from an alcohol point of view at licensing. And there's been some recent successes with licensing in Inverness, and how that affects alcohol consumption. So I think the importance is to see the good work that's been going on locally with things like the MAT standards, but to recognise the wider work that's needed, and that the ADP does in addition. One other thing that I was going to say is, well, two things really. One is that there's good news locally around drug-related deaths, but we do need to be cautious in terms of the national trends, and the rates are still exceptionally high. And the other, just on alcohol, we do need to remember the wider harms, both of substances, but also specifically of alcohol. And it's a bugbear of mine ever since I moved north of the border, that it's easy-ish to get information on alcohol-specific deaths or alcohol-specific admissions. What it's very, very difficult to do, and I've even just tried over the last few minutes, is to get any information on alcohol-related deaths. So conditions like heart disease or stroke, or various cancers which are contributed to by alcohol, but where alcohol isn't the single cause. And some liver diseases may be particularly prominent in that. And the information's really easily available south of the border, but for some reason it's almost impossible to get hold of north of the border. And I think now that's a particular bugbear of mine, and it's just something I'll continue to go on about. But I think the importance of it when we come to the paper is the contribution that substance use, and particularly alcohol, make to the general health and well-being, including people ending up in Raigmore.
Thank you very much indeed, Tim. That was very helpful for some more context, and I totally agree with you and support your quest for alcohol-related admissions and so forth, because they are key to it as well. Got quite a few hands up, so I'm going to bring in Mary.
Thank you, Terry. It was just a reflection more than anything else from feedback that I've had from within the sector in relation specifically to the DARS, the reassessment around waiting lists and whether or not people could be referred elsewhere. The feedback that we're getting is that the third sector services that are mentioned are now creating waiting lists themselves. So I think it's important that we understand that when we push these things on, they're there are limitations because there's no additional resources coming in for those services either. So I would have been remiss had I not made that point, Jerry.
And the point would have been made if you hadn't raised it, Mark. Absolutely, yes. We're not saying these people didn't need support of some ilk. They needed support, and that it just moves the bulge in the hose somewhere else. So yeah, I think that's a really good point to make. Philip.
Yeah, thanks, Jerry, and thanks, Teresa, for the report. I was noticing that there was an increase in the use of naloxone, which is great because it saves lives. But I just wondered if you'd be able to give us a bit more detail. There were almost 600 kits that were administered, but I just wonder, in terms of the distribution of those kits, how many are an unused resource in terms of how many there were, and of the 600 that were used, because of the expense of them is going up. Is there an issue with our distribution, and can we be perhaps more intelligence led with how we go about the distribution? Thanks.
I think that's a really good question. So if it wasn't used, then it would have expired. So I suppose it's people who are administered naloxone are people who are known to be using opiates, and people are asked. It's not a here you must have that. It's people, would you like this as part of a harm reduction initiative? So it's given to people that we know who are at risk. Part of the issue this year has been particularly in relation to there's sort of new generation of opiate type drugs that's going around, and we've seen that actually naloxone, the one dose of naloxone is bringing people out of overdose, and then they're quickly going back into overdose. So some client groups we've been having to give some more, like double the amount as opposed to single packs. So it's difficult. It's difficult. As I understand it, there's a good process in place. We hope that people don't have to use it, because if people are using it, they're overdosing. But it is given to people who have been identified at high risk of harm, as opposed to that kind of scattergun approach. I don't know if that answers.
Thank you very much, Teresa. And Anne.
Thanks, Jerry. Thanks very much, Teresa. Nice to see you again. And it's good to be considering this report. I just had a couple of questions. It seems like the development of the commission service for non-dependent use is pretty central to your improvement plans going forward. I wondered if you could give us a bit more detail about how that needs to be progressed and how quickly you think that might be able to do so. Will you have to bring a business case to EDG? Will you be applying to the partnership for funding, etc., just to try and get a sense of how much within, you know, how realistic it is that we can bring that to fruition. And then on a completely different task, I just wondered what you saw as the risks and opportunities posed by the opening of the new prison. I realise that's a bit forward, but I'm sure there are issues that we need to be thinking about now. Thanks.
Yeah, so in relation to the, sorry if somebody walked in, and the first part of your question was, now you'll have to remind me again, the first part of the question was in relation to the commission service. Yeah. So we'd actually done all the work in relation to the commission service. It was all sitting. We had done a bit of a soft marketing exercise, had spoken to various different third sector colleagues about what we were looking for, and we had done a bit of a service design. So that's all sitting, and that work's been completed, because what we were keen was that we had parity across Highland. We don't have parity at the moment. You know, some areas are better served with what's available, so we wanted something that was that was able to provide a North Highland approach. What then happened, though, was there has been a delay in progressing this. predominantly because of the delays in our finance being confirmed from Scottish Government. So that only came in late June, and it's been a bit of there's been some challenges about working out how much we have to take forward the tender. We now have, just recently, in the last few weeks, we now have managed to get some additional finance support for really firming that up and taking that work forward. I know that Arlene's on the call, and there may be some more that she wishes to say about that, about time frames. But where I'm at just now is all the background work's been done, the tender's been done. It's just that real ticking the, can we afford this? What can we afford? And having that formally confirmed, that would then enable that tender process and that commission service to come forward. So that's the first part. I just want to check if there's anything Arlene wants to add, or she's content with that response for now.
No, I think that summarises it. I've asked last weekend for a tender project board to be re-established this week, now that we've had the confirmation of the funding, to ensure that we've got timescales for that to be progressed.
Yeah, because you're absolutely right. It's key, and it's, you know, it really is key for us continuing to be able to deliver and continuing to progress. In relation to the second arm, which is, you know, what opportunities are there in relation to the new prison? Well, with an increased prison population, we are going to have increased numbers of people who are affected by substance use in whatever form. So there is a challenge there. We have a prison and healthcare working group, which is looking at some of the challenges associated with that and preparing for that. We have a target operating model for prison and what we're expected to deliver with our healthcare teams within prison, and we're taking forward that work. But it's certainly something to be mindful of and have sight of, is that our prison population is going to double in size in 2026, and with that there will be increased needs of the prison population. So again, that's something I would hope to have the opportunity to bring that back in due course and perhaps discuss that in more detail. Thank you.
Thank you very much indeed, Teresa. I'm not seeing any other hands, so I'll bring this item to a close. But I think just as last year, Teresa, your enthusiasm comes over.
Sorry, Neil.
Oh, Neil, sorry, late hand, you're up there.
Sorry about that, late hand. Yep. Sorry if I missed something in there. I was just picking up on the commission service for non-dependent use. So because of the restrictions on DARS, moving to dependents, so we'll have to have diagnostic clarities regarding dependents, and I think some of that is in the paper, and I note the NICE reference. Who do we anticipate, given the pressures on the third sector as well, who do we anticipate is going to provide the service for non-dependent use? Who would we be commissioning?
At the moment, it's unknown, because the tender would go out to all interested individuals, and that would then be scored, I imagine, on certain criteria and their ability to provide a North Highland service. There is a number of local agents, local third sector partners, and there is also national partners, particularly concerned with alcohol and drug use, substance use. So I don't know at the moment as the answer. And Aline's got her hand up. This is her area of expertise.
Thanks, Teresa. No, your answer was absolutely fine. I think what we have done was the soft market exercise, where we asked if anybody was interested in potentially tendering for it, but also to help us create what the spec should be, because we wanted to learn both from other areas about what other areas are doing and who is out there, and that was really successful. We had both national and local third sector organisations who came with ideas about what we could do, which we hadn't potentially thought about how to engage with individuals, how you could do that across Highland if you've not got a huge pot of money, and how you can actually do that through the use of technology, which is probably a bit more aspirational than we had been until we met with our national colleagues who are doing this in a variety of different settings. So that has been what has informed the spec that we've got going forward. But yeah, we won't know who would be the successful partner, but it would be a third sector organisation.
Oh, Teresa?
Sorry, and I just wanted to add to that, Neil, we couldn't even start to consider to move towards dependency unless we had that in place, and then actually there would be a whole governance process to move towards that there was assurance within the organisation that we were meeting the needs of everybody affected by substance use. So we've been able to trial that way in those areas because they have a good third sector representation, but there's everywhere else is not really in that position at the moment.
Thank you very much indeed, Teresa. Thanks for that question, Neil. That was useful. It's a good way of bringing, I think, the discussion to a close, and it's helpful to hear that actually we wouldn't make the change until we had the non-dependency commission service in place. So I just wanted to thank you again, Teresa, for your attendance today and your excellent report. And I think, as I said last year, the enthusiasm comes over so clearly when you're speaking, but also comes over in the report. So my thanks to you and my thanks to the team. And we've been asked today to accept moderate assurance, and it's my personal opinion that would be a very high moderate assurance, because I think what you've given us today, but you rightly recognise the challenges ahead there. And I can just ask that committee members are happy to accept that moderate assurance. Thank you. Seeing thumbs up. So thank you very much indeed to Teresa and the team. Okay, we're about 15 minutes behind, so I'm going to suggest that we take a comfort break now and come back again at 2:45, and we'll go into the Vaccine Improvement Programme update. I'm actually very confident that we're going to pick up quite a bit of time in the second half of the agenda, but we'll be back in the virtual room, in about 9 minutes' time with your refreshed caffeine pots. Thank you.